you. So, Dr. Ike is a global authority and a pioneer in managing, complex anterior segment cases. And, with the ease and coolness he does the surgeries and he does, them live is really, really remarkable. So, I'll just go through his CV. He holds this John Hazel and Robertson Presidential Endowed Chair. He's a professor of University of Utah. And he's the director of glaucoma and advanced anterior segment surgery, GAS Fellowship. He's an internationally recognized surgeon, scientist, and a pioneer of microinvasive glaucoma surgery, MIGS, IG. And he's among the world's most experienced complex cataract surgery that we all know. And the honors that he holds is he has a Bing Cross Medal. He is named the #1 most influential ophthalmologist in the world and holds the King Charles III Coronation Medal. So we are eagerly awaiting to hear your talk. So over to you, Dr. Ike.
Manish, thanks so much. I want to thank you so much for the invitation. And it was great to hear my good friend and colleague, Rajiv Muni from Toronto. He's just a few miles away from me. So it's nice to see the Toronto connection. And Manish, I want to give you a credit because you have such vision and eagerness and passion for ophthalmology and for surgery. And I want to support you and congratulate you for all your work. I see you're a young guy and you're a rising star. You're already a star, I think, already, and taking so many opportunities and leadership. So all the best to you. Thank you so much. Thank you so much.
We have the whole audience waiting for you, sir. We have around 250 physical audience waiting here, and there are so many of them joining you online. So it's going to be a big show here.
Well, it's already a big show, and again, thank you so much. I wish I could be there in person. Maybe one day I'll have a chance to get down there. I'll drag my friend Rajiv too with me, so we can take care of the front and back of the eye. Well, listen, let me get my presentation prepared here, and again, I wanted to thank you again for inviting me to be part of your symposium, the Kanpur Symposium. My talk will be focused a bit on the front of the eye. And I'm going to speak a bit primarily about complex iris repairs. It's an area that I have a lot of interest in. Patients come from all different aspects, whether it's congenital or traumatic or surgically or other causes. These require a real, holistic approach in managing these patients. These are my disclosures. And, unlike other parts of eye surgery, these patients require not just a visual outcome or a functional outcome, but they also require a cosmetic outcome. And I don't mean to say that in terms of being vain, but the reality is that, we use our eyes to see the world and the world sees us through our eyes. The way that we appear makes a difference in terms of our confidence, in terms of the perception of how we feel and how people feel about us. So, the iris is such a unique part of our eye. I really encourage us to really address not only the visual functional aspects, but also the cosmetic aspects, which are also important as well. The loss of iris tissue can be very traumatic to a patient, and often my patients come to me and they are more worried and concerned about their visual appearance than they are actually about their vision or their functional impairment. Obviously, though, photophobia and other issues are challenging. This is a young patient who had a traumatic injury to the eye and really lost her self-confidence. We repaired her eye, and she, really feels and felt that there's a improvement in her overall function in society, not just in her eyesight and her vision. So our goal here as eye surgeons is not just, of course, to address the vision and the functional challenges of these cases, but also to address, the appearance. And so I come with the premise of, the iris is one of the most beautiful structures of our bodies, and our goal is to reestablish the magnificence of that iris. Fortunately, we have a lot of ways we can do this with suture repair. That's going to be the predominant approach that we use. Current recommendations is to use a polypropylene suture. These are quote unquote permanent sutures, although there can be some degradation over time. And Tenno polypropylene is typically what I like to use, whether it's iris and pupil defects with a curved needle or nerdodialysis. I want to mention here that, this is a CIF4 taper cut needle. I don't recommend using a spatula needle. I see people use spatula needles and I see larger iris defects and holes made. I also don't feel that 9-0-proline is necessary either, because again, it also leads to larger defects. So our experience over the last 20 plus years has been to use 10-0-proline and use curved needles. Straight needles are more for iridodialysis repairs, which we'll show as well. You know, it's nice to have the right instrumentation, so I like to have Sinskys and Kulin hooks. And probably the most important thing is using the right microinstrumentation. You know, these are instruments that it can be used in the anterior segment. If you don't have one, you can steal one from your retinal surgeons. We require usually more rigidity of our instrumentation, and typically nowadays VR instrumentation are either, you know, excessively longer than needed, or more flimsy and less rigid to do the work in the anterior segment. They can be done, but many years ago, this is probably 20 plus years ago, we designed these in different ways. And I want to point out the difference between a micrograsper, which is a forceps to grasp tissue like iris or lenses, versus tying forceps, which are designed to suture and to manipulate sutures, just like we do for regular cases. Before jumping into cases, I also want to mention about how we hold instruments. I think too often we talk about you know, what's happening into the eye, but you know, how we actually hold an instrumentation makes a big difference in terms of how do we actually carry out the motion inside the anterior segment. And so we like different grips. Pencil grip is used. This is a common you know, positioning of your hands. I use this in some cases as well. Underhand is important. The dart thrower, in terms of holding it like a dart. And then the cigar grip, which is for me a very common grip. I use it for my phaco as well as overhand grip. And so we often take videos from the microscope just to be able to show how we move our hands, how we hold our instruments, how we twirl our hands, and how we really ensure that we use the fulcrum of the cornea. This is really important working in such small spaces and closed systems. And we published a book, you know, kind of going through an illustrated way to describe how to do these techniques. And we'll go through them here. So first premise here is to establish a few ways to tie a suture in the eye. And the classical approach is the mechanical approach. And this is a standard classical approach. Since then, there's been many new ways to tie sutures, and I'll express my bias in terms of what we use. They're all useful. They're all important to understand and to learn how to do. I will say that you know, whether you decide to do a 4-throw pupiloplasty, which has been something that is emerged out of India, or to do a 3-1-1 locking knot, up to you. I personally like to lock the knot, but whether you choose to lock or do a 4-throw, you still need to develop a way to tie a suture. And so it's important to have that approach. I'm going to show an approach that my fellows jokingly called Ike Ahmed approach, because it incorporates the components of both the mechanical technique as well as what I modified with it. And here's just when the suture needle going through the iris defect tissue. We come out through an incision, typically subincisional, and then we pull both ends out to the common incision. Here we use a micro-tying forceps to basically loop around the micro-tire with the long suture end and grab the short end and simply push it into the eye. It's very simple to do. To me, it's one of the more easier techniques to learn to suture. There's no futzing around with loops of sutures. We triple throw, we push it in, or do a 4-throw, whatever you like to do, and then we can go through another paracentesis and cinch the suture, tighten the suture. Taking the next level, we also have described using intraocular tying, where we basically use 2 microtires inside the eye to tie a suture. Again, these are not really complex ideas. They're simple ideas, but they require us to put them together to fix complex problems. Here's a challenging case of a patient who had a large iris defect. This patient has had a history of Flomax and had IFAS syndrome and had iris prolapse and loss of iris here. Our goal is to reestablish the pupil contour. The benefit here is that we can take advantage of the elasticity of the iris tissue to basically bring them together and close. Usually up to 3 clock hours can be closed. Notice how we make the paracentesis incisions far enough from each other to take advantage of the long CIF4 needle to allow it to follow that trajectory. The trajectory basically to allow the needle to be passed without traction on the iris. One thing that's going to be very important as we talk about suturing here is to avoid buttonholes in traction, because the iris can be very thin, especially in these traumatic cases or floppy iris. So there's that suture pass. We have the needle driver in a bit of an alternate grip, And now we'll take a Kuglen hook and pull the suture ends out of the main incision. So far, fairly straightforward idea. You did see I approximated the closure based on my visual imagination, so to speak, in terms of where we should be placed those sutures. We can use 2 forceps to do that. And then we basically tie outside the eye like we showed using the micro tire and then slide the knot into the eye. We can use another paracentesis to cinch that knot and basically bring the suture together. Now be careful again to avoid excessive traction because that's where we get holes and tears, and transillumination defects can be problematic, creating in some patients, dysphotopsias and light sensitivity. So now we will lock that knot. Again, I like to lock the knot. 3-1 is usually fine, or 3-1-1 like we would outside the eye, and there we have the closure. Now this is now continuing to close that iris defect. What does help sometimes is to take larger bites of the iris away from the defect. And what that does is what we call imbricate. It imbricates the tissue within the knot, and that allows us to close a larger defect. And you can see, again, we're basically being very cautious in how we tie the suture and how we pass the needle. And we now have closed that defect. You can see that there's better closure, but I'm still going to pass another suture. There's no frank defect in the area here, but the iris tissue is fairly thin and transilluminates. I want to overlap the good iris tissue over the area of thinning to allow us to close that defect. And there we see defect closed. Now, one of the most important parts of our patients' visual, not only visual, but their cosmetic outcome. And again, I don't mean cosmetic surgery as sort of being vain, but just in terms of establishing normal, appearance of the pupil, is the pupil itself. The goal here is to get a nice round center pupil, and therefore it's important that we approximate the edges of the iris pupil margin appropriately. Here we're showing intraocular tying using 2 micro tying forceps, and we will again do that triple throw and then cinch that knot. The pupil's looking better now, so we're happy with that. We'll then lock that suture and then cut the suture. And now we've been able to reestablish that patient's appearance. You can see the patient pre and post-op. And compared to the fellow eye, we have created a reasonable cosmetic result. So take the time to do it. I see a lot of surgeons rush through this. This case took probably an hour to really fix nicely. It was worth it. Now, sometimes we have an issue with corectopic pupil and the pupil's not centered. We have used endothermal pupiloplasty using a diathermy to do this. Like I often do, I steal instruments from my retinal surgeons, ORs. And here we're using a 23 gauge endodiathermy for iridoplasty. Now, this patient here, you can see, has quite a fairly decentered pupil. And my first premise is we're going to pass the suture needle. Now, where do we pass the suture needle? Well, that requires you to basically estimate where the margin should be. I recommend taking 2 forceps. I didn't show it here, but where we grab both edges of the defect and bring them together to basically approximate where that should be. The pass is made. We're going to tie the suture in the eye like we showed. And now we have the pupil starting to be closed. But what I'm going to take now is my endodiathermy and use this at the pupil edge to bring the pupil superiorly in this case. This is basically on the phaco machines. It's bipolar cautery, 0 to 40%. You don't need a lot of energy. And be careful not to go too aggressively. Otherwise, the pupil can be too far pulled over. We now will continue this suturing. And this is very much like if we were in the office using a diode laser or using a 532 laser to coagulate the tissue to do an iridoplasty. But here we're doing it in the OR, allows us to titrate the tension with our suturing combined with endothermal pupiloplasty to do that. So here our closure is looking nice here. But the pupil I'm still not happy with. I'm putting another suture in there. Take that extra time to make that extra bite. This is a lifelong treatment for this patient. And we're looking better, but I still want to get that pupil around. Here we're going to use the endodiathermy again. The farther away we are from the pupil margin, the less the effect. So start farther away. We can always get more. And the closer we are, the greater effect and the greater energy. So here you can see the pre and post-op appearance of the pupil, pre-op and post-op. We've created a better round pupil. This patient here had traumatic cataract and a large atonic pupil. These patients require a 360-degree closure, not just a closure of a defect. This is pupil cerclage, and cerclage is one of my most favorite and demanding techniques that we use. Notice that we're going to use both hands here. We're using that same CIF4 needle. The cataract's been done. The patient wants a multifocal lens. I wasn't very keen on it, but we went ahead and did that. She was a young patient and wanted to still, provide a range of vision. So notice what we're doing here. We're using the forceps to bring the iris to the needle, about approximately 6 bites of that iris with a rolling suture, passing this needle throughout the quarter of that pupil margin. Now we switch hands. I think it's always important to be able to use both hands, and we're using now our left hand on the needle. The right hand is doing the work, though. The forceps is actually bringing the iris to that long needle. It's hard to be able to maneuver the needle in the eye, but you can bring the tissue to the needle and come out of the eye with a cannula to avoid grasping the corneal stromal fibers as we go back out and into the eye. Again, we're basically doing a rolling suture. We find a rolling suture provides a nice round pupil margin. And really, it's just taking our time to pass that needle. People often say, you need to have really great hands. I think you really need to have more of a great mind as you think about this in terms of how to hold instrumentation, where to place the instruments, and where to place the motion. So now we've basically gone 360 degrees. We will use a regular tying forceps in one eye and a micro tying in the other eye. This is that quote-unquote Ike Ahmed approach. And we do a triple throw, bring it in. Now is the time we titrate the tension. So, and this gives us control. Now, if you're Dr. Mooney, you probably want to lead the pupil at 6 millimeters, right? Because I have good view of the retina. But I'm going to go about 3.5. I know my retinal colleagues will sometimes wish we had it larger, but I will say that, listen, we can always cut the suture if there's a problem. We can always use a laser, or we can cut it with a scissor. If the patient requires surgery, we can place iris hooks in there. Don't get the pupil down enough, then we get the right functional outcome and appearance and cosmetic outcome. Of course, the patient was a bad diabetic. We would leave the patient with a bit of a larger pupil. But I've, over the years, found this is reasonable. And usually with indirect ophthalmoscopy and scleral depression, we can get a good view of the periphery, good enough to evaluate the patient. But that requires us, again, to think about what the right size should be. So here you can see postoperatively the appearance of the pupil between both eyes, right and left eye with the adequate appearance. So dialysis repairs do require additional suture needles. I like to use a long, straight needle rather than a curved needle going across the anterior chamber to the sclera. And this patient has a traumatic cataract as well. The cataract was not the major issue here, but we'll prepare the sclera for the passing of those needles. First thing we'll do is here we will release the posterior synechia from the anterior capsule. It is generally a good idea to try to get to these cases earlier than later, before there's excessive contraction and fibrosis. But a few months later is fine. And we will use iris hooks here to keep the pupil margin away from our central space on the anterior capsule. Just a little bit of staining. We will then do our capsulorhexis. The cataract part was not the difficult part. It was soft. The zonules were reasonable, so we put a capsular tension ring in, and then we place our intraocular lens into the capsular bag. So now the time comes for repairing the iris. We're going to smoothen out. I heard the word steamroll, I think Rajiv used for retinal purposes with a bubble, but we're basically using the viscoelastic to steamroll and flatten the iris. And now we're going to approximate where do we place the iris back in the angle. Notice, by the way, my groove here. My groove here should be, this is basically the end of the blue zone. I'm going 0.5 millimeters posteriorly, or 1.5 from the limbus. Don't go too anteriorly, otherwise we may close the iris over trabecular meshwork, which would be less desirable. I've approximated where I want that iris to go. Well, they're going to do a mattress suture. Now, there's many ways to suture an iridodalysis. I'm using mattress sutures. Pass the needle through the iris first, and then 27 gauge needle is used, placing the needle through that groove and then going iris plane to capture the needle. Enter the sclera perpendicular to avoid being too anterior with this placement. You're going to notice here that my needle passes are farther apart on the scleral side than on the iris side, because we, of course, have a larger circumference that we're passing the needle when we go on the sclera than the iris in the angle. And that allows the iris to basically spread out or fan out. This is very much an art part of the surgery rather than just the actual science part of surgery. And we're going to do a slip knot. So, approximate where we need to go. I take the time to grab my forceps, grab the iris root, and bring it to the angle so you can approximate where it is. The other thing I want to point out is that where we place our paracentesis incisions are important. I've strategically placed this paracentesis and used the paracentesis depending on where I'm working. Too often I find surgeons force themselves to work through an incision, and that creates ergonomic challenges and also causes iris defect and challenges as well. Here again, we're doing a mattress suture on the nasal side, and we'll do a slip knot again. Here we will now finalize the temporal, the supratemporal area that we're closing, and do a slip knot. Now I have not locked the knot yet because I still have to repair the pupil. The pupil is atonic and dilated, and if I did the iridolysis repair alone, we would still have a problem with the patient having photophobia and having a suboptimal appearance. So we'll use a forceps to release any synechia that may be present. You can see the iris can be quite distended. People worry about bleeding. It's rare to see bleeding when we're suturing the iris tissue, fortunately, with the very small microvessels that are on the iris. But what can happen sometimes, though, sometimes if we pull too hard, we can get iris root bleeding. And that's something that we have to try to be mindful to avoid and use adequate tension. I already sort of cerclage, so I'm going to just fast forward through this. But we have to be careful, especially on this superior side. We don't want to pull apart our iris tissue. This is the hardest part because there's some traction there. So we have to try to be as careful as possible without putting centripetal force on the iris tissue. We'll do our 360-degree pass. And now we can, again, titrate the tension. This is why I like this Ike Ahmed approach. It allows us to really adequately titrate the tension what we want, using micro instruments in the anterior chamber to do that. And I'm going to tie the suture. I'm not going to lock it yet. We're going to basically then go out and do the dialysis suture. We're going to go back and forth to determine the adequate tension. And then we will lock the suture knot in the iris, on the pupil margin, and then we will lock the nuts outside the eye. So a lot of suturing, but you can see very methodical, organized, logical, and controlled, meaning, taking our time to do that case. And this is the patient after surgery. One day after surgery, you can see already the patient's looking better. And we really uplift the patients in terms of their overall, feeling in terms of society. Now, sometimes we don't have enough tissue to suture. This case, for example, we have insufficient iris tissue. And this is where the use of iris prosthesis can be very useful. There are a variety of different approaches. These are different diaphragm rings and sector shields that can be used. There are now, color matched iris. This is the human optics implant that I use. This is hand painted to match a patient's fellow eye. This patient actually had congenital aniridia and had cataracts. And I said, listen, we can, place an iris prosthesis. And I said, what would you like to have? And he said, I want to have the eyes like Brad Pitt. I said, okay, if you want to be like Brad Pitt. We took a magazine and we sent it to the manufacturer, and they basically made these irides. It's not the same thing as changing your eye color, by the way. That's a bad idea to do something when you already have iris tissue. But this is an iridia patient, and you can see the patient now looks like Brad Pitt. So we were able to really change lives here. This is a patient you can see has really loss of iris tissue, insufficient to suture. And so in this case, we're going to have to use a prosthesis here. This does add, obviously, some cost and hardware into the eye. This patient also has, almost a 6 o'clock hour dialysis, which we'll manage as well. When we do the capsular rhexis, it's important to center the rhexis on the lens, not on the limbus or the pupil, of course, here, and maintain an anterior capsular shelf that we'll need to use capsular devices, like, for example, the capsular retractor here from MST, which is nicely used to grasp the capsular equator and hold it in place. The cataract surgery is now performed as per routine using phaco chop technique in my case, and the capsular bag is nicely held in position here. So we're able to really stabilize the capsular bag despite the large area of dialysis, and using viscoelastics avoid vitreous prolapse and avoid the chamber from shallowing. And we now have the bag evacuated. I'm putting a capsular tension ring in to circularize and round out the bag, but this is not going to be enough, as you're going to see. And then I used capsule polishing. I used polishing, you'll see why. I don't want to have excessive anterior capsule pacification. That will, in this case, reduce the appearance of that prosthesis. Here I'm going 1.5 millimeters posterior to the blue zone, or 2.5 posterior to the limbus, depending on what your landmark is. I like to use the blue end of the blue zone. And now we've placed a capsular retention segment. We're putting a segment here because the CTR is not enough. And the CTS here, the segment here, will be used to segmentally support the capsular bag. This is 7-0 Gore-Tex. We've also used 5-0 or 6-0 polypropylene, and a flanged approach is another option as well. And now the IOL is in the capsular bag. So we've achieved now capsular bag fixation. We're going to measure the capsular bag is about, usually most bags are just around 10 plus millimeters. This is our custom-made prosthesis that is matched to the patient's fellow eye. And I'm going to I've cut the trephine using a corneal trephine to 10 millimeters. We'll do a trifold here. Now, this can be sutured to the sclera too. In most of the cases we do, the bag is already compromised, so we have to suture the implant to the sclera. But in this case, we have a capsular bag present. So we will allow us to inject this into the capsular bag. This is using the sapphire injector and the emerald injector from J&J to do this injection. This is a big implant. So you see it's pretty large going into the capsular bag. You need to put a lot of viscoelastic in and carefully allow it to fold using a reverse taco approach, tucking the edges in under the anterior capsule with the assistance of a hook and a forceps to place it under the anterior capsule. This is the part where we have to hold our breath to make sure we don't damage the anterior capsule. But the capsule, fortunately, is quite elastic, and we can do this. And you can see we've now created a new iris and a new pupil. I like to typically remove the native iris to, improve the appearance of the eye and also to reduce any risk of chafing. Although we're in the capsular bag here, so not really necessary in this case. And you can see we have a nice result here with the bag centered, the IOL in the bag, cataract removed, and we have an iris prosthesis, all sutured with the Gore-Tex suture, which I find to be a optimal suture for fixation to the sclera, and really doesn't break, but the knot has to be rotated into the eye. So there we have the result. This is the patient after surgery. We can see the CTS with the Gore-Tex. The capsule is cleaned because of the polishing, and we have a nice result. So I hope I've been able to share with you a few approaches with managing complex iris repairs and lens repairs. These are just some of my fellows from the past, and we have a lot of visitors coming to visit us. We've had many from India as well. So hopefully, if you're in the area in Toronto or interested in visiting, we look forward to seeing you. Our goal is to share and to educate and teach. Not always easy with all the regulations and the rules and the challenges that we have, but we want to make sure we get everything out there. And certainly the internet has been a good source of this, and it's been a great way for us to communicate and share. So Manish, that's my presentation. I hope it gave people some ideas, and the goal is not to make everybody do what we do, but is to inspire us to challenge and continue to learn and segmentally improve what we do to help our patients. Take the time to fix these. It's funny, when I started practice, I didn't know how many patients would come that would have these problems. It's amazing how these patients are around. A lot of them are not taken care of adequately or are ignored in many ways, and not everybody needs to have all this repaired, but I think it's nice to be able to offer this to our patients and really provide not just a visual result, but a holistic approach in terms of managing not just that, but the patient as well. So thank you very much. Appreciate your invitation here, Manish. Thank you.
Thank you. Thank you so much, Dr. Ike, for those wonderful presentation, wonderful surgery, wonderful skills. I mean, and believe it, he does all this work, he does it live. He has live surgery sessions with such complicated cases, and he does it with so gracefully, with ease and fun. He's really a master, master of such complicated surgeries.
Well, thanks, Manish. I mean, it is a mindset, right? So it's all up here.
So, if anyone has any questions to ask?
Ike, this is Gaurav here. How are you doing?
Oh, Gaurav, how you doing, my friend?
Good, good, good. It was as amazing. And
Gaurav's the master. He's the master. You guys all know that.
No, no. I mean, these are out of the world. These are like so many of these learning videos. I really enjoyed seeing them again, and especially the prosthetic iris. So I was only wondering that, with the human optics prosthetic iris, do you sometimes have situations where, you land up with glaucoma or something? And of course, you are the glaucoma guy as well. But do you see more instances of patients who didn't have glaucoma eventually develop glaucoma or something?
Yeah, I mean, it's hard to associate the elevation and pressure to to necessarily one specific part of the treatment. A lot of these patients have traumatic angle issues and traumatic trabecular meshwork damage and other issues. So their natural history itself predisposes them to glaucoma. Does the prosthesis itself do that? I think that it could, especially if, for example, the prosthesis is causing issues with direct contact to the iris, to the intraocular tissue. There have been some prostheses that had, some issues in the past, perhaps with the material that was designed. But I can't say I've seen, a direct correlation with prosthesis with what we use now. So I think especially if it's in the bag, I think really it's well sequestered from the other tissues. Now we often do suture this to the sclera, right? And sometimes if you suture these to the sclera, especially if it's an oversized implant, then we have contact with trabecular meshwork. We can develop inflammation, uveitis, even hyphemas that can occur. So I think especially when we're suturing to the sclera, which is how we do many of these, I think the importance to size this right, to avoid having direct contact to intraocular tissue. And with that, I think the risk of increasing the risk of glaucoma, I think, is less of an issue. But these eyes are just at risk. These eyes are at risk for glaucoma. They're at risk for retinal complications and corneal complications. So, these are tricky eyes to fix, and they need long-term follow-up.
Absolutely. Yeah, but thank you so much. And each one of them was spellbinding. So I'll pass on to Dr. Ramamurthy. He has a question for you as well.
Well, thanks, Gaurav. You keep on teaching, man. You're a great teacher.
Wonderful videos. I always learn from you. What if any of these patients had a clear lens under dialysis? What will be your approach?
That's tricky, my friend, because we know that the risk of cataract development is quite high just with any intraocular surgery, let alone if there's any damage to the capsule. So, I would caution doing this in a clear lens, and sometimes we have to balance out. Do we remove the lens to fix the problem or not? That's really an important discussion with the patient. Of course, there are other options in intraocular surgery. There's options using anterior contact lenses. There is, corneal tattooing, although I think that is, to me, maybe less desirable, in my opinion, at least. So, I think that, it takes a customized approach. Now, I have certainly do many iris repairs in patients who are phakic and left their lens. But aerodialysis is more challenging just because you're really working near that capsular equator. It can be done. I would be willing to do it in a smaller dialysis. I've done it in those cases. I certainly have closed, iris defects. That patient from the beginning, I showed a picture of with the cortopic pupil. I actually did her. She was phakic, and I left her phakic. And after maybe, I think 6-7 years, she had a cataract. So I went and did the cataract, and I was able to still maintain the iris sutures. So, or they can be opened up if needed. So it can be done. I just warned the patient that they may develop a cataract sooner than later. But if the patient's very bothered, I think that is something that worth considering. Obviously, that I wouldn't recommend doing this as our first few cases. It requires a lot of experience and being in and out of the eye. In this case, you want to go in and out pretty fast, right? Not have long surgery.
We have another question.
Hi, Ike. I am Dr. Malay Chaturvedi from Kanpur only, and I am also a state representative. And I am here to actually not ask a question, but to congratulate you for giving such a nice presentation. And I am also here to congratulate Manish, who has brought you here to our city and to our state. And we have been seeing such wonderful videos from your side, like what we saw with Dr. Muni. Dr. Muni is in our WhatsApp group, and we keep listening and keep hearing about him. We would like to have more of you in more of our fora in the city and the state. And one question which I had in mind is that your surgeries were mainly on the blue irides, whereas in our part of the country, the irides are brown. Will that make a difference in the ultimate outcome or the reaction? So after this thing, you can give your question and we'll be in touch. And thank you very much for joining it. Great.
Oh, thanks for your kind comments. And like I said, I hope one day I can visit in person. That would be a great occasion for me. You know, India is my home country, you know. हम थोड़ा सा हिंदी बोल सकते हैं, ज़्यादा नहीं, थोड़ा बात कर सकता.
Wonderful.
आप बोलिए, बहुत अच्छा लग रहा है.
Shukriya,
We
shukriya.
will listen.
Well, maybe when I visit, I'll speak more. But I can understand most Hindi. I can understand. I watched enough Bollywood movies, you know, to follow it. So good question. We have a lot of variety of iris colors and densities. On one hand, the blue irides may have less reaction, but they're more challenging because they are typically thinner and less robust. So there's a greater chance of having tearing and holes. The brown irides, which is thicker, will hold the suture and the needle passes will be more secure. On the other hand, the brown irides in patients who are, you know, from our background, have more risk of having more of a inflammatory reaction. We have not seen excessive inflammation, but it's important, of course, and I should have mentioned this, we do treat the patient aggressively with anti-inflammatories, with steroids for the first month after surgery. These patients have a higher risk, you know, for CME with all the manipulation. We keep them on non-steroidals for 3 months and we watch. So I haven't seen a major issue with brown irides, but our surgical approach and our post-operative course will be a little bit different, as you kind of highlighted there in those examples. So I think that's a good question, and we need to think about the pros and cons of either approach, but it can be done for both cases.
Sir, just one quick question before we conclude this session. I noticed that when you do a pupil cerclage, you use a curved needle. So what if you use a straight one? I mean, would that make a difference, or is there any difference between the two?
You know, I strongly suggest to use a curved needle. The problem with a straight needle when we're doing direct iris repair or cerclage is that, you know, think about you're going through the corneal incision. To actually angle the needle up and the iris tissue to go up and down, right? To do that to a straight needle is very difficult. The angle, the approach of the angle is steep. It's going posteriorly from the corneal incision down to the iris. So to make that manipulation and then to come out of the eye through another corneal incision, that curved needle is much more optimized to do that. So I really think a curved needle is what we should be using in those cases. The only time I use a straight needle is when I'm doing an iridodalysis repair, because in that case I'm going straight across the anterior chamber, going down, grabbing the iris, and going out through the sclera. So in that case, a straight needle is actually better to use. So it really depends on what we're using. You know, and the other example, you know, when I sutured the capsular tension segment, you know, when I sutured that to the sclera, I use a straight needle. The Gore-Tex suture comes on a curved needle, but I straighten it out because I want to pass directly across the anterior chamber, grab the segment, go out through the sclera, and a straight's better for that approach. So I think that depends on the approach, but for cerclage and direct iris repairs, I think a curved needle is a preferred approach.
And any suggestions on the micrograspers that you use for holding the iris? I mean, do you use the vitreoretinal forceps, or do you have any special ones?
Yeah, I mean, I think any kind of forceps is fine. I do think having a forceps is a good idea. I know many people just pass a needle without grabbing the iris. I think the precision on that is not ideal. It does require us to use both hands and have, you know, the right, ergonomics together. You know, we designed these. I designed these 20 years ago because we didn't have the right instrumentation, and we designed them for the anterior segment because, like I said, they're shorter and they're more rigid than the VR forceps because, you know, the flimsiness of those makes them harder to work in the anterior segment. So that's from MST, Microsurgical Technologies. Other companies now have come out with similar type of things for the anterior segment, but you know, obviously VR forceps are more widely available, and so, you know, they certainly are acceptable to do. But you will find them to be harder to use. They're more designed with smaller gauge, forceps and cannulas, and so. But, you know, certainly I would say maybe steal a few if you need to.
Thank you so much, sir. It was wonderful having you here, and we really enjoyed your surgery and learned a lot. and we hope to have you here with us even in future. So
Thank you very much. Thank you very much. Appreciate everybody and all the best. Manish, thank you very much. Congratulations to you for all your accomplishments already.
Thank you. Thank you, sir. This we conclude our International Symposium session, and we would like to felicitate our chairpersons.